Take over the session. Welcome, sir.
Okay. You- we had discussed about bacterial colitis and amoebic colitis. Now, some more of the varieties of the other colitis, like among them, virus-induced colitis. Of course, clinically not very significant, but somewhat important. The types of virus which can produce the colitis are many. Among them, in India and whatever we see, majority of the patients are rotavirus. Rotavirus is very commonly seen in our area, India, and often it occurs in the form of an epidemic, like some seasonal. Very often seen in end of the summer season, like April, May. Most of the rotavirus infections they tend to occur quite frequently in our area. Of course, the other types of the virus which can produce these are norovirus or adenovirus, cytomegalovirus. The majority of the presentation could be of three categories. Primary infection, which is more common, where it occurs usually seasonal, like as I said, seasonal, like in end of the summer, like you will have many of these patients. Now, some of the patients may become carriers to the virus, and these patients may have repeated episodes of the colitis, and that's what we call as reactivation. And the third variety of the viral infection is produced in case of patients who have some other infective pathology or immunodeficiency disorder. And among those superinfection conditions, cytomegalovirus is more commonly seen. And particularly the risk is very high in the patients who are on dialysis therapy for a long duration. If the patients are on dialysis therapy, where because of the reduced immunity, altered immunity, they are prone to develop cytomegalovirus infection. Of course, in HIV patients and any other patients who are on chemotherapy too, a cytomegalovirus superinfection can occur. Otherwise, in the routine clinical conditions, cytomegalovirus conditions are very few as such. Now, from the clinical point of view, it's the primary infection which we see more frequently than the other two varieties. The majority of the primary infections are not recognized because in particularly in otherwise healthy person, because it occurs as a simple minor episode of some loose stools and maybe pain in abdomen, low grade fever, which subsides in 1 or 2 days, and most of the times it's not really treated as such. There is no need of treatment also, or maybe occasionally there are simple treatments like some anandavira, some dietary changes or so on can cure the condition. Rarely a patient may develop recurrent symptoms which looks like irritable bowel disorders, like some of the patients who continue to be seropositive, and these may have the complications. Then immunocompromised patients have increased risk of complications, particularly those who are older than 70 years, and if they have some nutritional pathology. Patients with the HIV conditions or other AIDS-like conditions, or patients who are on steroid therapy or any other immunosuppressive medications, or patients who have undergone transplantation. There again, as I told you, it's a cytomegalovirus common issues. Then patients who are on dialysis, neoplasia malignancy, inflammatory bowel disorders, patients who have inflammatory bowel disorders, they also are more prone to develop these viral pathologies. Patients who are alcoholic and patients who have collagen vascular disorders, and due to the immunosuppressive therapy possibly, patients who are on repeated blood transfusions and who are malnourished, in these patients, the viral pathology may produce more serious complications. Otherwise, a viral colitis may not have any clinical significance. Clinical presentation is a fever, anorexia, malaise, usually short duration in the primary infections. But when it becomes chronic, it may result in weight loss, dehydration, pain, abdominal distension, nausea, or even watery diarrhea, which becomes very chronic, rarely blood mixed diarrhea, or patients may have constipation. And if a patient has a history of inflammatory bowel disorder, any of the other disease conditions which you have already referred to, sudden worsening also could occur in such patients. Now, usually in the primary infections, you don't need any investigations. Rarely we do go for the investigations here in our clinical setup. But suppose the patient is having a suspicion of viral hepatitis, also viral colitis, and persisting for a long duration. In such conditions, antibody tests and polymerase chain reaction tests are now available, and they can be done to confirm the diagnosis as such. Treatment protocol, of course, in the chronic conditions, the suggested treatment is antiviral drugs like intravenous ganiclovir, or even foscarnet, but the real benefits are questionable. Then the other main part of the treatment would be maintenance therapy to avoid dehydration, diet and exercises would be enough. In the primary infection, virtually there is no need of treatment, but whenever there is a pathology, usual prescription will be Mrityunjaya and Mustagaris. Chronic conditions comparatively very rare, and the third variety, super infections, of course, we may not treat them quite frequently. So that's about the viral colitis, one more type of the colitis. Now, another important form of the colitis, from the clinical point of view, very significant, is ulcerative colitis. Ulcerative colitis is virtually not much different from the other disease like Crohn's disease. These two are very similar conditions. Ulcerative colitis and the Crohn's disease are having very similar pathology. The differences are only few. Like in case of Crohn's disease, it's the proximal loops of the intestine which are involved, whereas in ulcerative colitis, it's the distal loop of the intestine which are involved, and slight difference in the clinical outcome. But as far as the pathology is concerned, they are very similar. Now, ulcerative Crohn's disease can affect any part of the gastrointestinal tract, whereas ulcerative colitis is limited to the colon as such. That's another basic difference. The exact cause is not known, and when the exact causes are not known, there are plenty of hypotheses to consider as the cause of the ulcerative colitis. Among them, one is considered as environmental factors. Ulcerative colitis is more common in Western countries where the temperature fluctuation is more, and the diet is primarily non-vegetarian. So maybe it could be related to that. Then immune dysfunction is also supposed to be the other cause. Now these days, it's now ulcerative colitis is having more weightage towards the theory of autoimmune disorder, because the antibodies now are being able to be identified. Particularly, human leukocyte antigen HLA-B27 is identified in majority of the patients, and hence it is considered to be an autoimmune disorder, or it could occur due to any other abnormality of the immunological system, either due to the treatment given as a treatment of other disorders, or at times it could be due to the extraneous factors where the immunity could be affected. And there is another theory is a genetic predisposition. There is a tendency for the ulcerative colitis to occur within the families also. So though the exact genes and their relationship is not yet proved, but many experiments have suggested that there is a genetic predisposition, and maybe in a few years, or maybe in the days to come, there could be the exact gene may be defined which is responsible for the ulcerative colitis. Another quite frequent identified possible cause is patients who use NSAIDs quite regularly. NSAIDs like paracetamol. Those who have a habit of consuming paracetamol for or dolo for any simple issues, they have a high risk of developing ulcerative colitis in due course of time. Other factors which are now coming up are, now again none of these are proved ones, but certain of the facts which are known are vitamin A and E, which are considered as antioxidants. They are found in low levels in almost 16% of the patients of ulcerative colitis when they have exacerbation. Now, whether this is cause and effect, still there is an argument or a discussion going on, debate going on. But what we have seen is clinically observed is supplementing vitamin A and E can produce some clinical relief to the patient, and hence it is supposed to be a cause there. Then psychological and psychosocial stress factors also are known to trigger ulcerative colitis. Exacerbations tend to occur, but whether psychological factors really cause the ulcerative colitis or not, again debatable. But what we have seen clinically is almost every patient of ulcerative colitis would have some stress symptoms, And stress relieving drugs like sedatives or tranquilizers often can produce a significant clinical resolution. So, cause and effect relationship with the stress also is somewhat, psychological factors also is somewhat debatable. Then the smoking, another very interesting issue is patients of ulcerative colitis often feel better when they smoke, whereas in the Crohn's disease, it's the other way. It may worsen the condition. So, though it's not considered as a clinical test, but it can give a clue, like if a patient is a smoker and if the smoking reduces the clinical symptoms, possibly the condition is ulcerative colitis. And if the smoking aggravates the symptoms, it's a Crohn's disease. But this is not tried as a clinical trial, like, so don't expect a patient to smoke and then find out whether the patient is relieved or not. If there is a history of that sort, that can give you some clues, like. And when another very common history is milk consumption exacerbates the disease, milk and milk proteins. So at one stage, initially in the early days, consumption of the milk proteins or sensitivity to the milk proteins was considered to be a cause of ulcerative colitis, but now it is disproved. It is now proved that it's not the causative factors, but patients who have ulcerative colitis may not be able to digest and absorb the milk proteins, casein, and hence the patient may have aggravation. Then other certain microorganisms also are known to present in a patient of ulcerative colitis, and they are Pectinatus, Citrullina or Fusobacterium, rare types of the species are seen in patients of ulcerative colitis. And administration of the antibiotics during the patient's exacerbation of ulcerative colitis can reduce the clinical symptoms to a certain extent, though the exact pathogenetic link is not yet proved as such. So, as far as the causes of ulcerative colitis is concerned, there is a lot of gray area. Nothing is absolutely proved, and the maybe the most possible and most dependable theory now is a autoimmune disease factor is the most dependable theory till now. Incidence of the ulcerative colitis is very high in European countries and American subcontinent. Comparatively, in India, the incidence is comparatively lesser, but still it is more than many other less advanced countries. So, we do see the patients in large numbers. About the data of in ulcerative colitis in India, very recently, since past around 2 years, there has been a nationwide IBD registry which has been established by a foundation called as Colitis and Crohn's Foundation India. So, because the incidence of colitis is increasing, ulcerative colitis is increasing, a foundation has been established, a NGO, this is a non-governmental organization, and this has now established a nationwide IBD registry. So, when you treat a patient of ulcerative colitis, till now it is not mandatory to register the patient, but it is better that you get the patient registered in the IBD registry so that the data will be accumulated, and maybe in due course of time you may have a situation where the patient's registration may be mandatory. As per the current data, this is a very recent data, maybe maximum 2.5 years old organization. So the data is not yet very much established. Like incidence of ulcerative colitis as per the Crohn's Foundation data in India, where they have they have registered the patients with that moderate registration facilities. It's not yet complete data, but it is seen like the ulcerative colitis is more common in the northern part of the country in ulcerative colitis, whereas Crohn's disease is comparatively lesser. Whereas in the southern part of the country, Crohn's disease is more common than the ulcerative colitis. But this data may not be very accurate. Still, it is one of the identified trend in the development of ulcerative colitis in India. Then the other factors which have been presented by that foundation is in the follow-up of 386 patients as such, the extraintestinal manifestations are seen in only 14% of the patients, and among them colon cancer is only 0.7% of the patients who have been followed up. But this data also doesn't confirm with or doesn't have a parallel situation with the Western data. The data in the Western countries is slightly different, But anyway, it may need to be followed up as such. The presentations also, as per their the presentations, of course, male sex is having a rather more frequent incidence than the females as such. This is what we see now as per the data here. Then the disease presentation, majority of the patients would have ileocolic, the distal area. But as per the global data, majority of the patients would have ulcerative colitis in the rectal area, proctitis. As per my clinical observations, when I have seen the patients, like with the limited number of patients whom I have seen, majority of the patients would have proctitis, rectal involvement, distal most part involved than really the proximal. But anyway, these are all the evolving data situation, and maybe in a few years we may have more accurate data. Incidence of ulcerative colitis and the Crohn's disease, both are increasing now as the time passes by. Every year there is a global trend of increasing the number of ulcerative colitis as such, and hence it is considered to be disease of the future. And the relationship with the lifestyle, relationship with the diet, these are now being established. The distribution, age distribution of ulcerative colitis, these are the global. Usually, the ulcerative colitis is seen at two peaks in the age group. One in the very young age group, early onset conditions, and relatively late onset conditions around in the 50s. This is the usual trend of ulcerative colitis developing. But no age group is absolutely immune. Ulcerative colitis in very young children also are now being reported, and again, it's one of the grey areas where the exact causes are not known. Based upon the involvement of the area, ulcerative colitis also is categorized as a proctitis where only the distal most portion is involved, then proctosigmoiditis or distal colitis where depending upon the extent of the lesion, or extensive colitis or pancolitis. Pancolitis is where the whole colon is involved up to the second. That's how it is classified. But this classification also is not very absolute, because as per the observations, and if you follow up a patient, now this is what's seen as the follow-up results, like patients who have initially presented with the proctitis only, in due course of time, after a follow-up of 9 years, these are the data from the Western countries, like by 9 years, a good number of patients may develop pancolitis. Now, this dark grayish color suggests of pancolitis, that light bluish color suggests of the left-sided colitis or partial colitis, and then you have the proctitis symptoms. So patients who have initially diagnosed as a proctitis, by 9 years, a good number of patients may have pancolitis or the other way, and the patients who have diagnosed as left-sided colitis initially may, after 9 years follow, a good number of patients may end up in proctitis or so on, or the other way, a patients who have pancolitis, very few patients may end up with the proctitis or the left-sided colitis. There could be a regression, but none of this has a very standard predictable pattern, and hence that kind of a classification of the patient as proctitis or left-sided colitis or pancolitis may not be very accurate or may not be very dependable permanent classification. But that classification helps in planning the management, because a pancolitis would have more severe complications and the treatment has to be more energetic, whereas the proctitis would be relatively milder condition as such. The clinical symptoms of ulcerative colitis are mainly diarrhea, and there again the very classical would be the more frequent movements of bowel at night. In the daytime, when the patient is active, when his attention is diverted to something else, the frequency may be less, and the frequency is more when the patient is having rest and he is more doesn't have any other diversional trends, and that's why many times ulcerative colitis is considered to be a psychological factor. So it looks like when you are free, you have more of the stools as such. When you are not so free, the stools may not be there. So this gives you a feeling like the patient may have psychological condition, but it may not be truly psychological issue. Some of the patients may have incontinence also because of very frequent stools, and then the proctitis, there could be leakage of the stools too. Some very few patients may have even a obstipation or constipation. Constipation or obstipation also can be a clinical symptom of ulcerative colitis. The another very classical is fecal urgency. Like the moment the patient feels the urge for defecation, he has to go for the defecation. Otherwise, there could be a leakage. Then one more very characteristic symptom is abdominal pain and tenesmus. Abdominal pain which could be preceding the defecation. Tenesmus at the time of the during the defecation, the patient may have that griping pain which may give a feeling of incomplete defecation, and the patient continues to sit in the toilet for a long duration. That also could be the other clinical symptoms. But one very classical clinical symptom is the nocturnal diarrhea, where the patient have more frequency stools at night. Then other clinical symptoms could be malnutrition, weight loss, nausea, vomiting, fever and fatigue. These are the common other clinical symptoms. A good number of patients may also have the symptoms in as extraintestinal manifestations. Among the extraintestinal manifestations, the most common would be the patients may have the peripheral arthritis, pain in the joints, or ankylosing spondylitis. And a good number of patients may have skin manifestations. Having a sclerosing cholangitis, where the patient may have a jaundice and the progression of jaundice in the hepatic failure. These are less common among our patients. In India, it's lesser, but their number is supposed to be more in the Western countries. And among the patients whom we have seen also, patients who are alcoholic, they have a greater chance of developing cholangitis or involvement of the liver, which ends up in hepatic failure, than really the other way. And about 3 to 5% of the patients may develop carcinoma, malignancy. It may become, it's also considered as a pre-malignant condition as such. The skin lesions produced due to ulcerative colitis, they are very characteristic, like where there could be a thickening of the keratin tissue, and there could be a glossy skin over the area. Patches of the lesions could be seen over the surface of the body. Then arthritis, the pain in the joints, also is very classical. The minor joints or major joints could be involved. Minor joints which may resemble that of the rheumatoid pathology, but unlike that of the rheumatoid pathology, the deformity produced is not classical. In the rheumatoid pathology, the deformity produced is what we call as a swan neck-like deformity, where the distal most phalanges would be extended and the proximal phalanges would be flexed like. Whereas in case of ulcerative colitis induced condition, all the joints may become flexed, or there could be a nodule formed at the Achilles tendon area, or even the knee joints also may have an effusion. If you do the CT scan, presence of the effusion in the joint can be made out. So these also are the characteristic stigma of the extraintestinal manifestations of ulcerative colitis. The pathological changes produced due to the ulcerative colitis are very classical. The ulcers are presented in islets. Some areas there will be a good number of ulcers, and then there will be some free area in between. And usually, initially, the ulcers seem to be superficial, limited only to the epithelial tissue. But characteristically, as the ulcers heal, there will be a increased epithelialization. The epithelial tissue will be formed, and that epithelial tissue formed would become more proliferated, and it looks like polyps, and these are called as pseudopolyps. A chronic initially ulcerative colitis presents as the ulcers seen in patches, then later on it can result in a pseudopolyp formation. See, at that area where the ulcers are formed, there could be thickening of the mucosa, and a polyp-like impression could be seen. It's not really true polyps, and hence it's called as a pseudopolyp formation. So if you do a colonoscopy, any of these features could be seen. Of course, a confirmation of these can also be seen in a microscopy. In the microscopic histopathology, if you send that, you will see the lymphocytic infiltration and maybe multiple small pockets of the pus seen in the submucosal area. Or it can result in the dysplasia, the thickening of the mucosa, and that pseudopolyp-like impression can be seen in the histopathology observation, and these are very classical to confirm the diagnosis of ulcerative colitis. Then if you do the colonoscopy is a benchmark diagnostic factor. The colonoscopy would be showing the different areas. A typical clinical ulcerative colitis would be seen as as I said, discrete ulcers or the pseudopolyp formations. Presentations of the pseudopolyps or discrete ulcers seen in patchy area. And whenever you do the colonoscopy, it's important that whole of the colon has to be examined, and these observations made in different zones also have to be made out, which can help to confirm the diagnosis of ulcerative colitis. Now, in this set of the images, what you see is the ulcers are seen in the perirectal area, rectal area, the distal most area, whereas the proximal, the areas of the intestines are free of the ulcers. Now, this identification of the lesions at the whole of the colon is necessary to grade the ulcerative colitis. And the other observation is whether there is a pseudopolyp formation or not. And of course, in ultrasonography, this colonoscopy, you would have to have essentially the biopsy also to confirm the diagnosis. Earlier, before the colonoscopy became popular, barium enema was a benchmark method. Diagnosis would be depending upon the barium enema. These days, barium enema has become less popular because of more inaccurate results. But in the barium enema X-ray, you may be able to see either a lead pipe-like area of the colon where the host stations are absent, suggestive of the colitis, or in the later stages, pseudopolyp formation, which looks like a thumbprint-like impression, serrated margins due to the pseudopolyps. It could be seen. So any of these could be the findings seen in barium enema X-ray. Or a barium enema X-ray also may show a string sign where there could be a significant narrowing of the lumen of the intestines, and it looks like a string as such. Pseudopolyp formations also can show you bead-like appearances. These are the classical radiological appearances seen in barium enema X-ray. The clinical difference between ulcerative colitis and Crohn's disease is the important issue. As I referred to earlier, ulcerative colitis is limited only to the colon, whereas the Crohn's disease is maybe ignoring the whole of the intestines, pan-intestinal. Even small intestines should be ignored. And very often, the most frequent site of the Crohn's disease is the cecal area, and it's often even may be presented as a mass in the right iliac area, which can be a differential diagnosis for the appendicular mass. Then, ulcerative colitis, there is a continuous inflammation, and characteristically the lesion spreads from the rectum towards the proximal area. That's the majority of the patients, not all. Whereas in case of the Crohn's disease, there could be some skip lesions, some areas of these ulcerative colitis, ulcers, and then the next is some areas of normal area. Ulcerative colitis lesions are usually limited to the superficial mucosa and submucosa only, whereas the Crohn's disease, the inflammation becomes more deeper, even the muscular layer could be not. And because of that, it can result in strictures, the constriction of the intestines, lumen of the intestines may become narrow. Perianal lesions like fistulae, they are very common in Crohn's disease, whereas in ulcerative colitis, not so common, but occasionally it can be seen. In ulcerative colitis, there will be no granuloma. You will not see a mass outside the intestines in ulcerative colitis, whereas in Crohn's disease, granulomas are seen which do not caseate. So, and hence you may be able to palpate the masses in the abdomen, either single or multiple masses, or even the ultrasonography can show you the masses. Specific tests, that's the antinuclear antibodies. When you study the antinuclear antibody studies, the specific nuclear is a perinuclear antibody is positive in case of ulcerative colitis, whereas this ASCA is positive for Crohn's disease. That's done when you go for the advanced investigations. In the ulcerative colitis, bleeding is more common, whereas the Crohn's disease, bleeding is less common. As I told you, fistulae, that's a repetition. Fistulae are rare in case of ulcerative colitis, whereas they are common in Crohn's disease. Maybe diagrammatic impression. Crohn's disease would be presented as deep ulcers, narrow ulcers which reach up to the muscular layer, and hence they may produce the constriction. And the distribution is maybe in the ileum or any of the small intestinal area. Rarely the colon is involved. Whereas in the ulcerative colitis, it's mainly the colon, and the lesions are seen as superficial ulcers, and which may result in pseudopolyp formation. That's the difference between chronic ulcerative colitis and Crohn's disease. Now, the treatment of ulcerative colitis, because the causes are not known, the prognosis also is poor, so treatment also is something like a graded response. The usual protocol, the standard guideline of the treatment of ulcerative colitis is the first line of treatment is considered as aminosalicylates, where the drugs like mesalamine and sulfasalazine are given. Or if the patient doesn't respond to this, then the second line treatment, that corticosteroids are given. Then the third line is when this also, corticosteroids also do not give a sufficient resolution, then immunomodulators drugs are given. I'll come to that somewhat later. And last resort is a colectomy. That's when it fails to resolve. From Ayurvedic clinical point of view, what I have seen is that many of the mild cases, first line would be Smithsagar, Gandhagar, and Bhairavi, and particularly patients who are limited to the proctitis level, they can be effectively managed with these drugs. But if the patient has a pancolitis, in this condition, this treatment may not be of significant benefit, where either you may have to combine it with the aminosalicylates or maybe the corticosteroids occasionally. Pichabasti is a game changer. Pichabasti can produce a significant change in the outcome as such. Now, as far as the common drugs involved are among them the aminosalicylates. The most common drug which is often used is either mesalamine or it could be the sulfasalazine. Sulfasalazine, again, it can be available in the form of either a plain tablet or a delayed release enteric coated tablet. Usually enteric coated tablets are preferred as such, and the dose is 2 to 6 grams in 3 divided doses. This is important. When sulfasalazine is given, the dose is 2 to 6 grams of 100 milligram tablet. That means minimum of 4 to 12 tablets in a day, depending upon the condition as such. And for the aggravations and the maintenance would be 2 to 4 grams, and of course it can be given. Or the other is mesalamine. Mesalamine, the dose is 400 to 1.6 to 4.8 grams again in 3 divided doses for the adult conditions. The other types of the drugs which are also maybe occasionally used are olsasalazine or balsasalazine. These are not very frequent used in our country. Majority of the prescriptions which we see are sulfasalazine or mesalamine. Then among the steroids again, it could be prednisolone, which is more frequently used as such in mild to moderate colitis. The dose again is 0.7 to 1 milligram per kilogram per day as such. The other hydrocortisone given may be intravenous in severe ulcerative colitis. The dose would be 100 milligram 4 times per day. These are the two more frequently used steroids in our situation. Others also may be used, but not so very frequently seen as such. Then the emerging protocols, lots of new drugs are coming up, and lots of research articles are presented, and these days this has become a fashion to go for the different types of the immunomodulator drugs, which they are claimed like they are very effective, but as far as in our situations, very few patients I have observed where this treatment is given, and still the patient may not have a sufficient resolution. Maybe in future you may have these drugs as the standard drugs of the protocol. Maybe in a few years, like in the coming days, the whole guideline may be changed, and these drugs may be considered as a choice of the drugs as the first line of treatment in future, but not yet. So that's about the options as such. Indications for surgery is if the patients have developed toxic megacolon which is not responding to medical management, or fulminant attack of refractory to medical management, a very fulminant attack where it doesn't respond to the treatment, that's an indication for the emergency surgery. Then a planned surgery or elective surgery could be indicated in uncontrolled colonic bleeding or patients with long-term steroid dependence, dysplasia or adenocarcinoma found on screening biopsy if there is a evidence of adenocarcinoma, or the disease presenting for more than 7 or 10 years also is an indication for elective surgery. That's about the whole gamut of the treatment for ulcerative colitis. But still the outcome is poor, prognosis is unpredictable. Then the other less common, less important varieties of colitis are ischemic colitis. Ischemic colitis, of course, is not a very common condition. It often occurs as a secondary to the other primary disorders. The other primary disorders could be atherosclerosis, embolism, vasculitis, and from the other clinical point of view is a hernia compression. Patients who have a maybe partially obstructed or maybe completely obstructed hernia, the intestinal loops may become blocked or ischemic can occur. Intra-abdominal mass lesions, trauma, cocaine, and certain of the drugs which also can trigger the ischemic colitis. The drugs which are known to trigger the ischemic colitis are digoxin, aspirin, and the phentermine, which is used as a drug for reduction of the medicine. Oral contraceptives quite frequently. Ephedrine, which is used in respiratory disorders. Phenobarbital, nasal decongestants, amphetamine, and interferons are tumor necrosis factors. Many of the antipsychotic drugs also can trigger the colitis. Ischemic colitis, when it occurs in the colon, the more frequent sites are mainly either the sigmoid colon or maybe the descending colon area, where the chances of the ischemia are more because of the typical pattern of the blood supply. Now, confirmation of the diagnosis of ischemic colitis can be made out with a primary, it is a plain X-ray where the whole loop could be dilated, or barium enema also, which can show a dysfunctional absence of peristaltic waves at the segment which is ischemic. Clinical presentation is mainly that of acute bleeding from the intestines, distension of the abdomen, toxic manifestations. Management is mainly a symptomatic management, nasogastric drainage, broad spectrum antibiotics, and the patients have to be maintained on IV fluids as such, and surgery is the last option in case of the ischemic colitis, where the ischemic loop has to be removed. Then the last part in the colitis is majority of these patients of colitis may result in a protein losing enteropathy. That's patient may tend to have loss of protein continuously from the colon, either due to the malabsorption or maybe due to the leakage there, and hence it can present as a specific disease entity which we see quite frequently, particularly in the old age patients. Now, a protein losing enteropathy can be presented due to as a complication of erosive like diseases like ulcerative colitis, Crohn's disease, or so on, or non-erosive diseases like sprue or intestinal parasites, or disorders causing increased intestinal pressure or lymphatic obstruction like tuberculosis or any other lymphatic obstruction as such. So the typical presentation would be patients may have pedal edema, distension of the abdomen, or in very severe cases, NSRK, generalized edema could occur. Weight loss and anorexia also are common, and patients also are more prone for susceptibility to the infections. Confirmation of the diagnosis done by a serum albumin level. Of course, typically the serum albumin level would be lesser in such conditions, and more, if at all, you have to have more accurate diagnosis. It's alpha-1 antitrypsin, which is done, clearance test done, though that kind of a test is not done frequently in routine clinical conditions. That would be more specific as such. There is no question of all that purpose of referring to this issue is there is no question of specific treatment for the protein losing enteropathy. Providing protein orally may not help the patient in recovery. In the patients who have a severe hypoalbuminemia, intravenous albumin may be given, but otherwise providing the protein would not be enough in such conditions. The only thing is the underlying treatment, underlying pathology has to be treated. If the underlying pathology is treated properly, then the protein losing enteropathy would be cured. Patient would recover properly. I have seen a few patients of ulcerative colitis developing this protein losing situation, and in that condition, my prescription would be usually Kumariasava. Kumariasava given can help the patients in recovery from the protein losing enteropathy when it is administered for a long duration. So with this, we wind up the colitis. The last part of the intestinal disorders will be neoplastic conditions, which we'll take up in the next session. So if there are any questions, you will try to answer and then wind up today. There are many questions like ulcerative, how much duration of, see for ulcerative colitis there is no question of specific duration. So it's a lifelong condition. So as long as the patient is taking or having the symptoms, you have to administer the drug. I never claim that ulcerative colitis can be cured completely. Then what are the immunomodulators? I have immunomodulators are the recent drugs like rituximab. I have given that list as such, the recent drugs. They are very new drugs, and very few patients are there who have taken that kind of treatment, and I have not prescribed that drug to any of the patients, and I don't suggest like it's an Ayurvedic treatment as such. So maybe immunomodulators are maybe the more what we call as a new drug sorts, and the experience of these drugs are comparatively lesser. So that's all the point which I could make out. Maybe in future you may have more these data about the immunomodulators being used in the ulcerative colitis in our country. Of course, Western data, you have lots of research articles presented about the immunomodulators in the your research field, but I take them with a pinch of salt as such. That's it. Then what should be the treatment in two different conditions and patient is having vomiting along with loose stools and only having loose stools? Of course, when vomiting and loose stools are there, the patient has a high chance of dehydration. So, and moreover, in a patient with vomiting, oral drugs administration may not be sufficient as such. So you may have to be more energetic, and intravenous fluids may be necessary in such conditions. Whereas the other way, it's the same thing. Otherwise, there is not much of a difference in the management. Then there is another one. Is there any category-wise distribution of Ayurvedic medicines also, if as per ulcerative colitis? Maybe, but my clinical experience is limited to only that. Smithsagara, Garbhakarsana, Anandabhairavi, Sagarishta or Pichabasti. Pichabasti is usually given in when the patient has a moderate aggravation. If there is a severe exacerbation, it may not be possible to treat that. Then which medicine to use? It first thin and lastly Pichabasti maybe. Okay, that's also true. Pichabasti can be raised. So, right, with this there are no more questions. Then there is one more question. How would the treatment differ in pseudopolyp formation? So there is no specific treatment for pseudopolyp formation. Once the pseudopolyp formation has occurred, it's always there is a high possibility that it can result in maybe neoplastic conditions. And as far as from our treatment is concerned, there is not much of a difference. The only thing is pseudopolyp formation suggests about more poor prognosis rather. Dr. Kanti has raised his hand, sir. Any issue, sir? Any questions, sir? Kanti, sir? No. Right. Okay. There are no more issues, so we'll wind up. Right. What should we do to if recurrence after surgery? It's true, recurrence after surgery are common, and then too I have some 2 or 3 patients who have had that recurrence, and my treatment is the same. Outcome would be poor. So the experience of treating the patients after surgery, recurrence surgery, is compared to lesser. Very few patients, maybe 2 or 3 recently, and otherwise there is not much of a difference in the treatment protocol which I have planned. So, is milk products. I suggest the patients to take milk. See, patients that milk being a cause for ulcerative colitis is now disproved So there is no question of avoiding milk and milk products. I suggest the patients to take the milk. Of course, in Banaras, the patients of ulcerative colitis were being given Takravasti. Takravasti was being given as a treatment protocol, but what I have observed is Pichabasti is much better than Takravasti. Takravasti produces more irritation, more pain to the patient, whereas Pichabasti is more comfortable. So now I am using Pichabasti. Earlier days in BHO, Takravasti was being used quite frequently, and that also produces some resolution. But now my clinical experience has suggested that Pichavasi is better. So milk products being a contraindicated in ulcerative colitis is a myth. It's not necessary. Patients can be given milk and milk products. That's it. Right? Sorry. Okay. No more questions.